Thanks. It's a real pleasure to share some of our interests and hopefully also share a little bit of the travel of how we got to where we are right now with you this morning. I'm going to go over a couple of things. I'm going to go over a little bit of structural background in terms of how this place works and a little bit of how we use funding and what's important in terms of funding, and talk both in terms of superstructure and in terms of general approaches where we're going in the future as well. And I'll try to keep this general, and Robert, as you've already said, if people have questions, please feel free to jump in and bring those questions up. This is a historic room, and it's a room that we actually use on an ongoing basis. Unfortunately, as a service chief here, I spend too much time in this room. I'm actually here almost every Thursday afternoon, and what we sort of find is the people who are in the regular chairs are sort of the backbenchers. So you have the opportunity to jump in anytime you want, raise a question, or bring up an additional point. So you are physically right now in New York Presbyterian Hospital, and the wood actually around this room was brought from the original New York Hospital, and the Society of New York Hospital has its charter just outside. It was actually given by King George in 1771. So in terms of the United States, at least, this is history. At New York Presbyterian Hospital, you have five campuses, but two primary campuses, one where Dr. Fenoy works, which is Columbia Presbyterian campus, and the other campus here, Cornell, which was previously known as New York Hospital. In the urology department here, we are a very broad group. We cover all specialties within urology. It's pediatric urology, female urology, prostate cancer, benign enlargement, et cetera. But we have one of the largest groups in the country in what we refer to as men's health, which is really infertility, erectile dysfunction, and testosterone action or production. And that's obviously what I'm going to focus on. We do both basic and clinical research, and I'll define that, and we educate medical students, residents, and fellows. Medical students, obviously, those are 4 years of medical school. Residents are those who have finished medical school but are doing specialty training, and fellows are those who have finished 4 years of medical school, finished 5 or 6 years of residency, and then they're slow like Dr. Paduch and myself, so they need a couple of years of specialized training to get them going. So the Department of Urology is a little confusing because technically I'm an employee of Weill Cornell Medical College, but we also work within New York Presbyterian Hospital. And I could talk about this slide for about 3 hours and kill everyone, and you really don't want that. We do have a couple of, and just to add to the confusion, if, for example, you move from this room down the hall, you actually go from New York Hospital to the medical school and back again. And again, hopefully we make this all seamless and just as a team that works together. So enough for New York Presbyterian, Weill Cornell. We also have our laboratories directly across the street on the Rockefeller University campus, and it's the Population Council, which is part of the group there. And Dr. Matt Hardy, who will speak a little later today, will talk about that. Dr. Alex Travis, who has done some work with them as well as with ourselves, comes from Cornell University, as does Dr. Cohen. We also have interaction with Memorial Sloan Kettering Cancer Center Hospital, which is where Dr. Stahl is supposed to be today, but I stole him away. And also with Columbia University, as I mentioned, with Dr. Fenoy. You're not interested in all of the other subsections except for men's health, and the male reproductive medicine and microsurgery group really works very closely with our IVF or infertility group as well, and that's a key advantage of what we have. These numbers probably don't mean a whole heck of a lot in terms of perspective, but basically suffice it to say that the Department of Urology is primarily and actively involved in caring for patients, both as outpatients, which is the 30,000 visits here, as well as patients who go into the hospital. About 4,000 patients per year go into the hospital, and there are a lot of operations or procedures that are done within the hospital as well. It is a growing department. These are just two types of procedures that we do, and you can see from 2003 up to 2007, we have fairly dramatic growth in certain areas of the department and the type of surgery that's done. If you look at men's health alone, we see about 2,000 new patients per year and actually consult long distance with another 100 or so patients per year. There's about 700 procedures per year, and that's increasingly progressively. We have 8 to 20 research protocols, and there's a wide range there because there are many different definitions of what a research protocol is, and if you added up every patient who has some sort of evaluation can be as simple as saying, someone who was treated 5 years ago, how did they do? You could come up with perhaps 50 research protocols that may be going on in any individual year. And again, the patients who are involved in research, you could put at the thousands or at the hundreds, again, depending on your definition. We do publish about 30 papers per year or presentations, and we are one of the largest men's health group, not just in terms of the number of physicians, but in terms of the productivity of the group. And I don't think there's much question about that throughout the country or throughout the world. We do have research programs within the department in a large variety of different areas, and although these do not seem to be directly related to what you're interested in, the way that science works is that developments in one area of science, for example, in the area of inflammation or infection, may be very helpful and translate back to our understanding of, for example, how the testicle works. So having these groups together is part of our plan, as I'll talk about going forward, and I think that helps to build the cadre of scientists who works together. You'll also notice a couple of groups that are referred to here. I mentioned nanotechnology and bioengineering. These are actually groups that are on the Ithaca campus. So although they're 200, 250 miles away from here, just like Dr. Cohen and Dr. Travis are situated 200, 250 miles away from here, we have a lot of interactions that try to bring together all of the resources that we have, and Cornell Ithaca is clearly a resource that works together with the medical school here. Research can be broken down to some degree into three general categories, and I'm going to make these distinctions and sort of define this so that it's a little clearer why you have different types of presentations today and what we're trying to do overall. At some level, we are responsible for all three of these, and basic science refers to the most direct evaluation of normal processes or disease processes, and it may, for example, look at the subtle details and genes that could be involved with how an androgen receptor, something that directs how testosterone works within a cell, how that segment of the cell actually interacts with other parts of the cell to make it work, and in fact, it may get down to such a micro level that it has absolutely nothing to do with patients at all. Basic scientists will often build on that theme and gain a much greater understanding of how those subparts of the body work, particularly now at a gene level, and how the products of that gene, usually a protein, interact with other parts of the cell. And again, that may be very distant from looking at a patient or a person, or how problems can actually show up as being something that we have to deal with in infertility or behavioral disorders, etc. Translational research basically takes some of that basic science and tries to apply it to patients. And as I'll talk about, probably the biggest new effort of the medical school right now is to develop translational research activities so that basic science is supported but we try to keep a link between that understanding of what's going on at the sub-micro level and how that can be translated into improving patient care. So, for example, it may be not just identifying what that defective gene or protein or disordered process is, but developing a treatment for that or a way to change how that abnormal activity occurs so that you actually help a patient who is affected with that. And again, that together is referred to as translational research. And then clinical research, which is probably more of what we do than anything else, is predominantly collating the results of treatments that have been provided. Sometimes you design those treatments in advance. Some people get the treatment and some people don't, to compare exactly what the effects are. Usually before you go to that level of a clinical research project or trial, you'll actually see how it worked when you treated a series of patients previously. But in either of those forms, that together is referred to as clinical research. Clinical research is essentially unfunded, meaning although the National Institutes of Health is very interested in promoting patient health and promoting research, there's almost no mechanism to directly allow you to do clinical research through the National Institutes of Health support. Laboratory research that we do, both the basic and translational, requires laboratory space, so you have to pay rent for that, requires research technicians, supplies, and that is funded in part by governmental grants and in part basically by philanthropy. One of the things that we do a lot of, and frankly is important to our reputation, is to do this sort of directed research. In other words, research that aims to ask a relatively limited, specific question that's directly relevant to a patient or disease. For example, are aromatase inhibitors a class of drug useful in treating men with Klinefelter syndrome? That is a relatively directed sort of question to ask, and basically that's not extensive enough in terms of its development, either from the beginning of the question to when you start to get answers, or in terms of the steps along the way, for the government to be very interested in funding it. Although it's unfunded, we think it's critically important for patient care, and fortunately, very often when we start with a study like that, we can gain enough of an understanding to tweak the government's interest that it may be important and have enough scientific background so that it's worthwhile to be considered for research government funding. If we look at the Department of Urology as a whole, we spend roughly $1 million a year on research. Unfortunately, only about 20 or 30% of the support for that comes from federal grants. The majority of it, fortunately, does come from income from an endowment that we have. So when you saw James Buchanan Brady Urological Foundation mentioned at the beginning of my talk, that's the foundation that actually supports a lot of our research. We do have some directed income from donors. We also have very small amounts of drug or industry grants. Generally, the drug or industry grants are very directed and very limited in their scope, and it's sometimes the tail wagging the dog in terms of pushing you in a direction rather than where we may think the best direction or the most fruitful research can go. And we get some limited educational grants as well. But as you can see from this, the yellow slice in this pie chart is predominantly research we fund ourselves overall. As I mentioned before, it's not just the Department of Urology, but our interaction with the IVF group, both the physicians who are gynecologists who take care of patients, as well as a laboratory that makes direct observations on sperm and how sperm and eggs interact together, as well as a population council at Rockefeller, as well as our colleagues at Cornell Ithaca and at Memorial Sloan Kettering. They're all parts of men's health research. In end, we basically take money from what comes in from patient care. So the financial driver for the department in terms of doing research is in large part are taking care of patients. But overall, what we do in taking care of patients really determines how research can and does proceed. So at the simplest level, the difference between the doctors that you'll meet today and the average doctor that you see is that the doctors that you'll meet today and who will speak today are doctors who have as part of their job improving patient care in addition to providing patient care. And it turns out, and I'll give this example again and again because it really explains a large part of why we're here, if you see a number of patients with a given condition and you think about it, in other words, if you have an open mind to what you're actually seeing in front of you, it gives you the opportunity to gain a new insight into what may be causing some of the underlying problems. And just speaking with Mr. Shelton a couple of minutes ago, we're talking about how Klinefelter syndrome, for example, is a relatively common condition. But there are very, very few physicians who actually are experts in this area. And what happens is doctors see one or two patients, but they may not put together what happened in that patient with what happened in the next patient. We also have a series of observations that could be occurring in kids where diagnosis has not been made in the past that now can be applied to possibly change their development and potentially change the outcomes or some of the effects of their condition as well. So exposure to what the clinical questions are, what the conditions are, can help us a lot to then determine what we can do for better treatment and to better understand what's going on that's actually causing some of the manifestations of a condition. It also allows us to formulate what the best research questions are. And then if you have a research group that can start to look at those things, and that's why you're going to have presentations by Dr. Cohen, by Dr. Travis, and by Dr. Hardy, you can then start looking and asking back and forth, well, if you're observing this and this means X, what does that tell us about the underlying condition? And if those observations are correct, what does that mean in terms of what we can do next? So what we think we've put together here is an interdisciplinary group where our clinical activity, in other words, our seeing patients and taking care of patients and making observations there, accelerates our ability to do research and then to provide new treatments and move on from there. So it's hopefully a spiral that continues to work up. One of the major clinical developments, which was basically sorting itself out as I was making a career decision about what I would do when I grew up, is the development of improved assisted reproductive technologies. And by that, I mean in vitro fertilization and its sort of sub-steps. So in vitro fertilization, I'm not sure everybody's background, so if I'm too basic for some people, I apologize. And if I move too fast in technical details, I apologize as well, and I'm sure I'll make both types of errors. But in vitro fertilization is a process where women are treated to produce multiple eggs. They're treated with a series of hormone shots. Those eggs are taken out of the body and then fertilized outside of the body. And then of those eggs that fertilize, in other words, embryos, some of them are transferred back to the woman. And it's a way to increase the chance of pregnancy occurring. The initial problem that was identified with men's infertility, or what we call male factor infertility, is that weak sperm won't fertilize eggs. And even when in vitro fertilization was initially developed, it was thought that male factor or weak sperm essentially couldn't be treated with this technique. But a series of adjunctive procedures where sperm and eggs are brought closer together, and in the end, in a technique referred to as ICSI or ICSI, individual sperm can be injected into individual eggs and get over that barrier of fertilization failure or difficulty with fertilization. we've come up with a very effective way to potentially treat almost any condition where there is limited production of sperm. And that was a background that really was critical to our ability to move forward. Up until that time, treatment of men's infertility was really a descriptive event. You could describe lots of things about it, but you had very, very few treatments that you could apply which would make a difference. IVF was looked at as, by some physicians as replacing any possible treatment of men's infertility, and we've looked at it as really the opposite. We've looked at it as a way to open up the possible windows to treating patients that have never been treated before. So again, we looked at that as a real opportunity, and we're very fortunate here at Cornell that we have a great IVF group led by Zev Rosenwax that's allowed us to foster those opportunities. So there is a specific condition that we considered completely untreatable before, and it's called azoospermia. It's a lack of sperm in the ejaculate. And it can occur because of blockages, and if the blockage, for example, occurred because of vasectomy, you could undo the vasectomy and reattach things. But for a majority of the men, you couldn't come up with a surgery to reconnect the system together, so basically those men were untreatable. Their only options were use donor sperm or adopt children, and we considered them sterile. And we considered them sterile as late as 1989, 1990. What we found is that there are live sperm that are actually present within those men. We also found that those live sperm could be used with these in vitro techniques and advanced procedures to bring sperm and eggs together, and that basically allowed us the opportunity to treat men with unreconstructible or unfixable problems with blockages causing the lack of sperm in the ejaculate. And it actually brought an entire group of patients here together, and they are men with a condition that's called CBAVD, or congenital bilateral absence of the vas deferens. So basically, what happens with these men is they have normal development of their testicle. They have very little development of the plumbing outside of there, which is supposed to carry sperm to the ejaculatory area. So you get a condition where men are making sperm, but the sperm can't come out. Now, that vas deferens is one of the most efficient tubes in the body. In fact, it's probably the most efficient tube in the body. So replacing its function is still something that's not very feasible. We were able to treat a handful of these patients successfully who could never be treated before, and all of a sudden we had the opportunity then to go ahead and see dozens and dozens of patients, and then hundreds of patients. And eventually we've now seen thousands of patients with this condition. The average urologist in his lifetime or her lifetime would see and treat or attempt to treat or just diagnose and send on to adoption one or two of these patients. Within a couple of years of developing a treatment for them, we had seen hundreds. So what that allowed us to do is it allowed us to make some observations and figure some things out about these men that had never been figured out before. So we characterized where they stood. As we saw more of the patients and successfully treated more of them, of course, we could better figure out how they could be treated and what made a difference in treating them. We're also able to figure out, because there are significant advances in genetics that were occurring, that most, if not almost all of these cases actually had a genetic cause. So it's a genetic condition that led to this lack of development of the plumbing, if you will. And then work this back and forth over a series of several dozen publications. And it even led us to treat men who had the disease of cystic fibrosis, which sort of the cystic fibrosis gene turns out is really the underlying cause of this malformation. These were men who, from a medical standpoint, usually didn't live into their 30s. Now they routinely were, and now we could routinely go ahead and provide treatments for them. The next step that we had after we had sorted out how to treat those men who had normal production is to look a little more closely into what occurs within the testicle. And each of these steps I'm sort of going over step by step, and they seem like they're very logical progression. But I got to say, when you are treating a group of patients, you sort of stop at some point, and unless you think about where you stand or think about what the next step is, or frankly think outside of the box, you often aren't able to get to another treatment or another step or another opportunity. And one of the things I like about both working with medical students as well as working with families and patients is that you often get questions that initially seem to be a little out of whack because they don't fit with what you know or you've seen before or what the medical texts say. But often those are observations on their own that for a person who has an adequate background and an open mind can take that information and then translate it to the next step, to either a newer insight or at least the opportunity to ask another question and figure out what the condition is, what the problem is. So one of the things we were looking at that point in time is a testis biopsy. It was the only tool we really had for looking within the testicle and sorting out what was going on. And we actually did a study where we identified that not just the men who have blockages, but even men who had sperm production that was so limited that no sperm appears in the ejaculate, some of those men had some sperm within the testicle. So that's a pretty amazing thing. Even if your sperm production is so bad that no sperm make it into the ejaculate, you can still have at least some parts of the testicle that are making fully developed sperm. And in fact, it probably require 3 or 4 million sperm that you're making in the testicle before the first sperm comes out. Well, this was a completely novel concept. And frankly, we published a paper on this subject in 1993 and didn't actually even figure out what the significance of it was. We were just reporting on a series of biopsies, and we were reporting on a sort of subset detail of the sperm that we're seeing, and we never figured out that what we were actually observing is that some men with this very low production had sperm within the testicles. And again, if we could use those sperm, then we could go ahead and treat them. Unfortunately, this observation was used by some other people around the world, and so they actually jumped the gun based on our observations to use extraction of sperm from the testicle with the assisted reproduction to go ahead and start to have children. Well, we caught up very quickly, and by 1995, 1996, we were moving along very effectively, and we're getting a little better success rates than some other groups had in terms of taking sperm from the testicle and using them with IVF. I got to say the techniques we were using at that were really pretty crude. Since we started to successfully treat some of these patients, again, these patients started flocking to Cornell, and that gave us the opportunity to make a whole series of additional observations. One of the observations that we made, and again, the patients with 47XXY provided one of the most clear and classic examples of this, is that you had certain specific hormonal differences in these men, and those are differences from what you see in the general population. That led us to a potential treatment, and Dr. Paduk is going to talk about those observations, what we think they mean, and how that can be carried forward in greater detail later. Just like the men with congenital absence of the vas, we're also able to sort out the spectrum of genetic conditions that could cause low sperm production or be associated with low sperm production. And we were also the first group to actually identify that certain genetic conditions were more likely to be treated than others, or more likely to be treatable than others, and that can direct what step you take next. It's not just doing a bunch of tests to sort out where things stand because you get more information. It actually drove you to decide what to do next. One of the difficulties that we had was actually sorting out how you get sperm out of the testicle. And this is just a picture of a testicle. It was actually removed from a cadaver, and the red is where the artery was injected. And what you can see is that the artery or blood supply to the testicle spreads out over the testicle and limits somewhat the ability to actually get into the testicle. And one of our early observations, fortunately from other doctors who are treating patients, is that if you do certain types of procedures, you can actually damage the testicle in doing that. Fortunately, this was, again, an opportunity where we learned from the patients that were coming to us and put two and two together to say, if you use such and such approach, and we thought about what you have in terms of the blood supply to the testicle, that could actually be the cause of problems and not just a way to treat. So it also opened our eyes to say we really need to move forward and develop a more effective treatment so that we don't damage the testicles that are so critical to patients and to our ability to treat them. And so fortunately from the very beginning almost, we were able to say we're going to develop treatments that keep in mind the blood supply to the testicle. As we were doing that, we also recognized that these blood vessels that run along parts of the testicle can also, if you look at a very high power through an operating microscope, you can actually see that there is a difference between areas of the testicle that work because they're bigger, they're whiter, and those reflect parts of the testicle that have more cells and therefore are more likely to contain sperm than other areas of the testicle where the tubules, or the part of the testicle that's supposed to make sperm, is smaller and thinner. Smaller, thinner tubule has fewer cells, is less likely to contain sperm. So all of a sudden, instead of just taking larger and larger tissue samples out, we're able to micro-selectively look throughout the testicle and just take the areas where we're most likely to find sperm, limiting the involvement of our biopsies, limiting the involvement of our procedures, and we've subsequently seen in hundreds and hundreds of patients that that's a very effective way to go ahead and treat patients. I'm not going to show the details of that whole procedure unless anybody's specifically interested in that, but basically what we're able to show is that the approach using an operating microscope that we refer to as micro-dissection testicular sperm extraction is more effective than the previous techniques that were used. There are several other investigators that have validated our results and also found that it's more effective. And again, as time's gone on, we've been able to identify that certain subgroups of patients are able to be effectively treated, even those that have previously failed to have sperm retrieved. So this is actually a figure from a paper that came out recently by a medical student who worked with us, who's now a resident in training. And what it looks at is it looks at a series of patients who had come here either after having had a biopsy or not having a biopsy, and often they had 2 or 3 or 4 or more biopsies per testicle in an attempt to find sperm. So those who had no biopsies before, which is basically right here, the 0, those who had no biopsies before were able to find sperm about 55% of the time if we use that sort of detailed micro approach. But even those that had 1 or 2 biopsies per testicle before could still have sperm found, and in fact, they could have sperm found almost as frequently as they never had a biopsy previously. So what does that mean? That tells me that a single biopsy in these patients really doesn't tell you much about what's going on in the testicle as a whole, and all you need is one small area of the testicle that is making sperm to be able to successfully treat those patients. So from a fertility standpoint, this sort of validated what we expected and what we thought before, but again, is really changing the landscape in terms of how you look at patients who have low sperm production. And again, men with 47XXY are probably a classic component of this. A lot of physicians, sure, Lenny?
Is age a factor in any of this? Is it a variable
That is
any
an
of
excellent question, and I actually have in my bag a paper that suggests that age is one of the more important factors. But our experience so far has been that age is not a very important factor, meaning if a man is 20 or a man is 45, the chance of finding sperm within the testicle appears to be very similar. Now, there is some suggestion that that changes to some degree during adolescence, meaning as boys, for example, go from age 14 to 18. I don't think those data or that information is compelling enough to go through the involvement or potentially the risk of a biopsy, which may yield sperm that may have to be frozen and may not survive freeze-thaw. But that's certainly an area that we're very interested in getting more information and learning more about. And actually, this is one of the areas where Dr. Paduk and I sort of debate back and forth. One of the nice things about having a group together is you can disagree about some things, get some information to support or refute one position or the other, and get a little more rapidly to the truth of what the underlying, what the true answer actually is by tossing things back and forth. Sure.
How does supplemental testosterone play a part in this?
Sure. So the body primarily works, let me flip back a little bit. The body primarily works in terms of making sperm inside the testicle by driving using hormones to the testicle so that testosterone is produced from here. And in fact, the concentration of testosterone within the testicle is about 15 to 20-fold higher than it is in the circulation. So if you give testosterone from the outside, your body senses that there's enough testosterone in the circulation. It stops making those hormones, LH and FSH, that drive the testicle to make testosterone and make sperm, and it essentially can shut this whole system down. The concentration of testosterone within the testicle, if you're receiving testosterone through your whole body primarily, this concentration of testosterone drops to the same level as is present in the rest of your circulation. So the testosterone level within the testicle that's so important for driving sperm production drops 15 to 20-fold. Your net effect is you get a blood test and it says, yep, your testosterone's 100 points higher than it was before, but in terms of the testicle, you've shut it down. So in general, we think that there's a balance between giving testosterone and maintaining fertility, where if you do give testosterone from the outside, you should monitor those patients very carefully to make sure you haven't shut off the body's internal production of testosterone, which is a little tricky because the testosterone's measured the same way in the circulation, but at least you can measure these hormones, the LH and FSH, that are trying to drive the testicle. So if you give too much testosterone, that LH and FSH level will drop. But if you give just a whiff of testosterone in some patients, you may be able to provide some circulating testosterone and maintain the stimulation of the testicle and sperm production as well. So in general, you have to be careful about testosterone replacement. In general, we do a little better in retrieving sperm from men who have not received testosterone, but I think you can have a balance between the two. Overall, when we talk about patients who are 47XXY, that's really a subset of about 10% of the patients we've treated overall with low production as the cause of no sperm in the ejaculate. We've now done over, this is actually as of May, so we've done well over 800 attempts at sperm retrieval. We get sperm about 59% of the time overall, 71% for men who have non-mosaic Klinefelters. The eggs that are obtained, most of them will fertilize, and the chance of having a pregnancy is about 47% overall, about 43% for the men who have Klinefelter syndrome. And again, this assumes that the testes really are not working very well, that the FSH is significantly elevated. So some of the things that are important at this point in time, we've learned that men who have low production are very likely to have genetic abnormalities, that using this sperm extraction technique we can get testicular tissue, and that actually gives us the opportunity to further study and analyze what's going on within the testicle, because there's always little bits of tissue that don't survive that process of removal. It also gives us the opportunity in treating patients to look at some of the hormonal conditions, and it turned out about 2 years ago we realized that our interest and direction in terms of sorting out what goes wrong in this process of sperm production was exactly the type of questions that Dr. Cohen and her group were sorting out in other animal models in the veterinary school. So basically, we're able to develop collaborations with people who are really advanced experts looking at the same types of questions or concerns that we were. I won't get into that other part. So taking this all together, this is actually from another talk. It talks about where we stand. We're proud, obviously, that New York Presbyterian Hospital as a urology group is highly ranked. We're certainly very interested in keeping this group very active and effective. And one of the major next steps that we have in the next couple of months, we're going to start deconstructing about 9,500 square feet on the 9th floor of what's uniquely referred to as the A building of Weill Cornell. This is a reflection of work that has been done over a number of years. If you look around the medical center here, you'll see a series of new buildings. There was not a new building in this medical school for 40 years, but the hospital, which is behind you over there, was built in 1997. The building across the street, referred to as the Weill Greenberg Center, was just built and completed this year. And there is another building which is going to go up on 69th Street, which will be translational research, and that, plus other infrastructure, plus helping to bring on people like Dr. Paduch, has resulted in some significant fundraising drives. The Phase 2 fundraising was completed for $750 million. Phase 3 is $1.3 billion. It's actually half completed right now, and a significant component of that is to help us to work together between the medical school and Cornell Ithaca, both in bioengineering, and certainly our interaction with the veterinary school is a critical one. The hospital itself, as a technically separate entity, is actually raising $1.7 billion. About half of that's being spent up where Dr. Fenoy is, and the other half down here. And out of that, it doesn't seem like much money if you compare it to all these other numbers, but I consider it a lot of money. We also raise about $2 million per year for these laboratories for our next steps going forward as well. And fortunately, we've got a lot of donors who have been very generous with us. That funding goes towards completion of the urology laboratories, and we just have received a major gift in support of that. Recruitment of 3 to 5 new research faculty, so these are PhDs who will be within the department and do essentially basic research, but they will be very involved in translational research. That's why they're within urology, a department that takes care of patients. We're also going to expand into this translational research facility, which is what I talked about over on 69th Street. And what we also plan to do is to enhance cooperation with other departments, including specifically the Department of Radiology. And when Dr. Paduch talks about some of the studies that he's doing right now, these have been developed really hand in hand with our Department of Radiology. And what you find is when you're, for example, trying to develop new imaging, new ways of looking inside the body, you often essentially have to develop a new machine to do that. That requires the physicists and the basic individuals who work within radiology to develop those to address the types of questions that we want to address and that we need to address. And from a practical standpoint, our goal in doing that is to try and sort out, for example, what's going on within the testicle without doing a biopsy, without doing something that's invasive. So, for example, if we're trying to follow kids during what we think are the critical time periods of development from, say, age 12 to 16 or 14 to 18, we can actually see what's going on within the testicle without doing biopsies of the testicle that could affect the testicle directly, could cause scar tissue or other changes, plus be painful. So what we're hoping to do is to find ways so that we can develop new treatments, monitor the effects of those treatments, and move them forward. Doing that is a lot more complicated than describing it, and Dr. Paduch will go over some of the challenges that occur just step by step in making that happen. The reality is, until we get some of those steps moving forward, we have no chance of completing the process. And it is unlikely that some new imaging or some new technique to help us to evaluate patients is just going to fall into our laps. If we want this to happen, we're probably going to have to make it happen ourselves, or at least help to drive it. The good news is, if we make a couple of those steps, if we start to develop an understanding and show that we can have some success, the government will then jump in with some funding. It's an odd dance, which Dr. Cohen and Dr. Travis can describe even better than myself. Sometimes you have to prove to the government that you can do the research, and it's a fine line between having enough done so that you've proven that you can do it versus being so far down the road in completing the project that they say it's already done, you need to go on to something else. Anyway, we also hope in putting our laboratories together and in collaborating together with the veterinary school to provide a rapid throughput. So as we identify, for example, something that interacts with testosterone within the testicle, we'll be able to sort out very quickly how we can change that, how we can improve how testosterone works, or how to keep it better so that patients can be helped. And through this whole process, we're also developing what we refer to as a clinical trial infrastructure. In other words, a way to take patients and directly evaluate them as they're going through treatments so we can help more cleanly sort out what works and what doesn't. Obviously, the next patient who comes in the door, we want to provide the best care possible. Sometimes you get caught in the trap of doing what you think is best without proof that that actually makes a difference. So clinical trials are a way so we can actually test, and you've got to be very careful about that balance of how you test a treatment, but test whether a treatment that you're developing works so that you don't give people useless drugs or useless treatments in the future, but you aim them towards what's going to be most helpful. And again, one of the ways that we thought we could be accelerated in that process and be the greatest benefit to patients is this imaging project that Dr. Paduch will describe in more detail, and I think is really critical to our opportunities for the future. So those are the things that I sort of wanted to provide as an overview. I hope I haven't confused you with what we do and why we do it. I've got to say that the support that has been provided, both in terms of information and financial support from KS&A, has really been critical to us. We are not here just to ask for money. We are here because we enjoy the partnership. We learn from patients and families and people who are interested in the same area. And frankly, you have helped us tremendously to develop interactions with other physicians, with other healthcare providers that I think are critical for our better treatment of patients and better understanding. And we're delighted that we have this connection. Thank you.
I want to introduce somebody that introduced me to you, which is Doug Lawrence. And as bring Doug up, I'm going to say he's an amazing man who probably spends a lot more time on the road than I do. But last year, KS&A started something when we created an award called the Lifetime Achievement Award. And as many of you know, in 1942, Dr. Klinefelter discovered there were 11 men who had a height that looked like mine and long legs that looked like mine, and that had a rare disorder. They had other symptoms that fortunately I don't have, but Dr. Klinefelter described that condition as an endocrinological condition, and then about 1959, 17 years later, Patricia Jacobs discovered that there was an extra X chromosome in each of those individuals. And so we created an award in the name of Dr. Jacobs and Professor Jacobs to honor an achievement in advancing the science in the recognition of what was happening with this condition that Dr. Klinefelter initially named, that could bring us to a point where a boy could be born with an extra X chromosome and actually grow up without the manifestations of the kinds of symptomology, the kinds of phenotypic characteristics that Dr. Klinefelter originally identified. So to sort of drive this difference between a boy that's with an extra X chromosome and ultimately someone that that doesn't have the problems associated with that Dr. Klinefelter saw. So the first step that we saw in that was Dr. Jacobs' accomplishment, and we named an award after her called the Patricia Jacobs Lifetime Achievement Award. And I've got it over there, and Doug is going to present the second recipient of that award to Peter. So he keeps this one. So one of these keeps this one. So this is the award that actually is a legacy award, and so it says Lifetime Achievement Award Patricia Jacobs. There's two names on it right now. Patricia Jacobs is on the top in 2006, and Peter N. Schlegel is October 2007, and then hopefully we'll fill the rest of this surface area with other people who we can thank for changing the lives of anyone born with an extra X or Y chromosome. So, and then there's one that you can keep.
Step forward, please. Here. My name is Doug Lawrence. I'm not the one that found Dr. Schlegel. It was Lenny Wilson that found Dr. Schlegel many years ago, when I was in complete panic about our son that was being born with this mysterious condition called XXY. And it was Lenny who guided me through Mount Sinai's medical libraries, through the New York University medical libraries, through Cornell's medical libraries, to try to come up with an idea of how to provide our son the best way possible to live his life. So the charge to Lenny was find someone who thinks out of the box, who can cut across the silos of medical information and connect it all in plain English to a dumb guy like me. And please find someone who doesn't care that they're different in terms of their thought process. So Lenny found a story about someone who created life out of death. A story of a doctor here at New York Presbyterian Hospital who helped a child to be born from a husband that was dead and a mother who wanted a child from that man, and ended up changing the way Social Security actually works and makes awards. I said, who's that guy? Peter N. Schlegel. So Dr. Schlegel, it is with great honor that we give you this award of a man who can cut across all kinds of thinking and thoughts and push science forward to help our children, to help our adult males. We honor you, sir, and thank you very much.
In rebuttal, I've got to say, first of all, we don't consider this a lifetime of work because we still have what I'd consider a lifetime yet to go, but we're pleased by any steps that we can take moving forward and just appreciate the opportunity to do that day by day. As I remind Dr. Paduch every day, it's a wonderful opportunity that we've got to be able to help people. Thank you for your support.